Hello, and welcome to Cancer Close Up, the podcast from the West Virginia University Cancer Institute in Morgantown, West Virginia. I'm Samantha Hall, a nurse practitioner here at the Cancer Institute. Today, we're going to be talking about genetic counseling and testing with myself and my colleagues, Christen Jordan and Amanda Moran. Christen, you want to introduce yourself first?
So again, Christen Jordan. I'm a physician assistant in hematology oncology and specialize in genetics here.
I'm Amanda Moran. I am a physician assistant with the Department of Surgery, Division of Surgical Oncology. I also specialize in the treatment of breast cancer as well as hereditary cancer genetics.
Perfect. So we get a lot of referrals for genetic counseling and testing, and I frequently have patients come in and not have any idea what they're doing here. So Amanda, do you want to talk about what genetic testing is, who gets referred to us?
Absolutely. So the big question on the table for patients is why do we do it and why it's important? And so basically we're screening your genes. I tell all of my patients the goal of the genetic testing is to determine why maybe we're seeing cancers happen in families or cancers happening in the patients that we see. And so it's all about preventative medicine. Can we figure out why it's happening? If we can figure out why it's happening, then the goal for the patient as well as their family members is really to help, modify treatment decisions, test other family members, preventative medicine. So can we identify and prevent maybe what the things they are at risk for developing?
Yeah, absolutely. Screening people closely to prevent it or at least catch it early, right? Because we all know early detection is the key to potentially cure. Yeah. So when we do these visits, we sit down with people. Christen, do you want to walk somebody through what a normal visit looks like for these people and what they should expect?
Absolutely. So at first, when we introduce ourselves to the patient, let them know a little bit about our background, we let them know that we've looked through their medical record. And at that point, we're going to ask them questions about their medical history so that we get a complete picture of them. This will help us because, one, it helps us to understand, are they eligible for genetic testing? Do they have anything in their personal history that would put them at higher risk for certain genetic syndromes? It also helps us to understand if they come back positive for something, how to manage them, and what their baseline health is. Additionally, from there, we go through a pedigree and we draw out their family tree. We want to understand a 3-generational pedigree of their family there. And so we ask about their parents, their siblings, their children. We ask about their grandparents, aunts, uncles, and generally first cousins. Now, some people know more information and we take that as well.
Sometimes we call grandma during the appointment.
That's right. Send out a quick text message. And sometimes nobody knows anything, and that's okay too.
Exactly. But we look at any pathology that they have on hand. Sometimes if someone had a breast biopsy or colonoscopy, those type of things can be helpful. And then we talk to people after drawing out their family tree about what we think that they can be at risk for, given the fact that they've had either a personal or a family history of cancer. We talk about genes that we'd be interested in, and we explain if they come back positive, what that would mean, and if they come back negative, what else we can do recommendation-wise to assist them.
Mm-hmm. Absolutely. So one of the big questions that I frequently get asked is how much is this going to cost me, right? This is thousands of dollars out of pocket, but that's a common misconception, right? I think when we all started doing this, it might have been $1,000 out of pocket.
Yes. Lots changed.
But that's changed now, right? There's a lot of companies out there, a lot of things you can test through. I tell everybody to be a little bit careful with those direct-to-consumer testings and all of that, because we do get those. But the testing that we do is usually covered by insurance.
Correct.
If it's not, usually the self-pay option is less than $250.
Yep, correct. You're exactly right.
So then that's a good thing for patients to have and to know, is that they're not going to be spending their whole retirement account on this one testing. And then, things usually get covered pretty well, right, by the company.
Yeah, and that's the whole goal of documenting and detailing that family history, is we're able to identify which patients qualify for genetic testing, which of those patients are going to have that testing covered. And if they don't qualify, we can still do testing on population-based screening. So again, just as a preventative measure, and quote those patients exactly what they can expect to pay out of cost for that testing.
Absolutely. And the other key with that is that, a lot of these genetic labs have programs that will actually, give them some financial assistance, essentially. And then if they do test positive, many labs will allow a 3 to 6 month period where they'll offer free testing for family members.
That's right. And then on the back end of that, when we start ordering things, right, breast MRIs, colonoscopies, usually we don't have a whole lot of trouble with those getting covered either by insurance companies. Right? We have a leg to stand on. We say, hey, your breast MRI is needed on top of that mammogram because your lifetime risk of breast cancer is 50-60%.
Yeah. So depending on the things that we find with genetic testing, most of the time we can explain to patients that there are clear-cut risks associated with these germline mutations, either the specific cancers that they could be at risk for, and then we follow NCCN guidelines, which is the National Comprehensive Cancer Network, and they basically lay out what their risk is, how we should manage them, and then those are the guidelines we use to target their insurance companies for coverage. So we're not just ordering testing because we think that we need it, we're ordering testing because we know that they need it and we know that insurance is going to cover that.
Mm-hmm. One of the things you talked a little bit about earlier was also impacting treatment decisions, right?
Yeah.
These results have more impact than just say we're ordering a mammogram for you or we're just giving you this.
Yeah, so the important part to consider with genetic testing for both patients as well as providers, especially in the setting of cancer care, is that, it has a potential to impact pretty much every aspect, from surgical decision making to targeted gene therapies, depending on the mutations that we find, future screening and prevention for those secondary cancer risks. So it has the potential to modify not just their treatment decision making, but also those of their family members to come as well.
Yeah, preventative health is really where it's at, and that's one of the things that I hope that genetic testing and cascade testing of their family members can contribute to, is it bringing down the number of cancers that we see in our communities. But yeah, Amanda is correct. We think about what type of surveillance does this patient need? A lot of times, in addition to looking at NCCN, we have to look at their health and then what's in their family tree, and then actually tailor, or what we call personalize, their management, according to what we're seeing.
Yeah, that's an excellent point. Yeah, one size does not fit all.
Absolutely.
So we really apply the information that we learn subjectively to each patient, and you guys patients help us make those decisions. We tell them what their options are, what their risks are, so that we can help them make well-informed decisions. Sometimes I see that when patients come in and they're actually fearful that a positive result will obligate them to do things that they're not comfortable with or that they don't want to do, which unfortunately is not true and certainly not the case. But we have very detailed, thoughtful decisions about what the patient's comfortable with, what we would recommend, and how they would like to proceed moving forward.
Yep, absolutely.
Shared decision making.
Absolutely.
Decision making is right.
Yes.
Absolutely. So another thing that we're seeing more and more pop up, at least from the medical oncology standpoint, is somatic testing, right? There's it's becoming more and more prevalent in all types of tumor now, as opposed to just the couple it started with, and that is impacting treatment decisions, certainly. But then some of those end up showing up on germline testing, and then sometimes we get patients coming in with these results, but those are actually from a tumor. So Christen, can you kind of explain to everybody what the difference between germline and somatic sort of means?
Yes, so germline actually does refer to what we've inherited or been passed down from a parent. It's what we're born with, and it's in each of the cells of our body, essentially. That is a predisposition to a disease, whereas somatic is actually something that we acquire over time after birth. And so at some point, if we develop a somatic mutation, if we get 2 somatic mutations and it essentially prevents that gene from functioning, we call that gene silencing, then we could, essentially get cancer. These are driver mutations when they are seen in cancer, and they're often targetable, meaning that a physician, an oncologist who orders the testing can often target that gene mutation to treat their cancer.
So sort of the important take home is there are different kinds of testing out there, right? What we do a lot is the germline side of it, but you can, if you have a history of cancer, you might have another report that says you have these mutations. Those are not necessarily floating around in your DNA. They're not necessarily things you can pass along. More testing is required, right? And
Correct.
So that's the thing. I frequently get referrals for this, and they say, look, I have these mutations, and then we backtrack a little bit, right? This is actually on the tumor itself, maybe in your DNA, maybe not in your DNA, but that's what we have to figure out during that appointment.
Yeah, to say the least, testing gets very busy very quickly, depending on what we're testing and what we're looking for.
Yep.
Sam, you are correct. Some of those patients we do get referrals on are not just because of their personal history and how they present or because of their family history. It's because of something that the oncologist saw on their tumor testing and that they were worried about because of the, we call it a variant allele frequency, but essentially it's the percentage of cancer cells that had that mutation. And it can be because it's a strong driver, but it can also be an indication that something is present in their germline that they inherited from the parent.
One of the things that we maybe didn't mention earlier that I was going to is, when we talk about this testing, we talk about coverage, and we talk about, things that patients are a little worried about as far as insurance goes, is that in 2008, there was a federal law signed into place, right? GINA, the Genetic Information Non-Discrimination Act, that actually says that that medical insurances cannot discriminate against you based on the results. Because some people get worried that they're now too high risk to cover. Oh my goodness, I have a higher risk for breast cancer. My insurance is going to know this. I'm never going to get coverage again. They're not going to do these things for me, which is not the case because there are federal laws protecting them, at least for medical insurance, right?
Correct.
That is very much correct.
The life insurances and certain other things are not included in that law.
Correct.
So that's a different story.
That's a different issue. Yes.
Yeah, unfortunately, GINA, it's a really great act. It does protect individuals, from not being discriminated against, as you said, for medical insurance, but it does not cover life insurance. It doesn't cover disability. It doesn't cover those, long-term care insurance policies, unfortunately.
Yeah.
So some of the time, we do talk to patients about that, and they may want to secure an insurance policy, especially life insurance policy ahead of undergoing genetic testing, just so that they have that in place.
I've absolutely had a few people walk out of my office like, well, let's just slow down and let me do it. Let me line up a couple other things.
Yeah.
And then I'll come back later.
And that's a great point. When you present for genetic counseling, just because you come to the appointment and we talk about everything, you're not obligated to do the testing at the time of appointment. If you're not comfortable, if you have more questions, if you need to think about it, if you want to check with your health insurance or your coverage criteria, you are always welcome to come back and do it at a later time. We certainly don't want to put anybody through anything they're uncomfortable with or just not unsure about.
Yeah, absolutely. So let's talk about who should get referred, right? We get all kinds of referrals, and that's getting more complicated. Who should get referred is getting more and more complicated by the day because we're having this discussion of
so
we
busy.
just test everybody, especially everybody with cancer. And so then who do we bring in?
Yeah, so I always break genetic testing down into two major groups. Genetic testing based off family history of cancer, and then genetic testing when you're talking about the person with the cancer and how it might apply to their treatment planning. And oftentimes those kind of cross cover each other and they're very busy. But ultimately what we're looking for are family histories that have not just a lot of cancer, but your specific types of maybe more rare cancers. And the patient may not be able to recognize that, which is the whole point of sitting down and talking about it. But, when we talk about rare types of cancers, we talk about ovarian cancers and pancreatic cancers, early onset breast cancers, or maybe everybody's diagnosed older in life, but there's just too many than what you would naturally be seeing. When we talk about the cancer patients, oftentimes we're looking for maybe those more significant receptor statuses like triple negative breast cancers. Any patient with a pancreatic, any cancer patient with an ovarian automatically meets criteria for testing. And again, that's not just to figure out, can we apply more of that precision-based medicine, so those specific treatments that target those germline mutations that they carry, but also once we get them through that treatment, screen for those secondary cancer risks so that we can try to prevent or early detect something else that they might be at risk for.
Yeah.
That's exactly right. Eligibility criteria just continues to expand. Amanda touched on, anybody with an ovarian cancer diagnosis, a pancreatic cancer diagnosis, but also a colorectal cancer diagnosis, metastatic, cancers of, especially prostate qualify or high risk prostate qualify now. And then in addition, it continues to expand for their family members. But, as Amanda said, we look for patterns, so if there's 3 or more breast cancers in a family, even at any age of onset, or if, maybe it's melanoma and pancreatic that we're seeing. And so it really helps us to get that family tree on paper so that we can really look at that and make decisions that are smart for the patient. Our approach to testing now is multi-gene panels. So we've come a long way.
Oh, back in the day, remember when we did detected 2 genes.
2 genes. Yeah. Now we had to go back and test for more.
We had to go back and test everybody, but now everybody is getting full-blown panels.
Yeah.
Pretty much regardless, because there's, I mean, as we've talked about, there's so many people who just don't know. Right. I mean, sitting down and looking at it, I don't even know if I know my own family history all that well.
Right.
You've got large families that go back generations, and then some people don't like to talk about their diagnoses with their family, or sometimes they tell you something and maybe they were unclear on their own diagnosis. So then those are all things to consider, that like maybe we don't have the full picture, we have some of the picture, so then these multi-gene panels are also kind of helping us.
Very much so, covering maybe the things that we can identify just through that verbal history. And I also just want to touch base, because we talk about so much genetics, you know, breast cancers, colon cancers, it's all becoming so much more common. And we're starting to see our ages of onset get younger and younger. Now, when we talk about the incidence of breast cancer or colon cancer, or just malignancies in general, it's important to note that the majority of cancers that we see will be sporadic in nature. You know, statistically, we say that about 85 to 90% of cancers are kind of spontaneously induced by those inherited mutations that you elaborated on. Only a small percentage of malignancy, around 10 to 15%, will actually be identified to have an associated hereditary cancer gene with it. So we certainly don't want to make anybody panic when you listen to this and say, hey, I've got that in my family history. But certainly it warrants investigation.
Absolutely.
Although that's statistically likely, the majority of the time, we may not find something.
Yeah, most of the testing we do is negative. And in which case, like you said earlier, we revert back to the family history. If you've got a really strong family history of breast cancer and negative genetic testing, that doesn't necessarily mean we just let you go. Right?
Yes.
Then there's also a component of this where we still follow people, or we still recommend that maybe you have some extra screening. Maybe there's a gene out there that hasn't been discovered. We don't know. We don't know where medicine is going to go. We don't know where genetics is going to go.
Yeah.
But just because it's negative doesn't necessarily mean
that we can't help.
That we can't help. Correct.
And we could have a negative person who has a family history of the gene that just hasn't been diagnosed in the relatives that have had the cancer. So that happens sometimes too. And so that's why even extending testing to their family and having them talk to them, well, hey, it'll help me understand my cancer risks better if you have testing. Because if we prove one of these genes was the cause of their uncle's pancreatic cancer that they didn't have, that really helps us to better manage that patient.
Yeah, absolutely. So as I think about the appointments that I go through, the things that are super important for me to have patients show up with is that family history, right? You usually know your own history. We can get through those sorts of things, but knowing who was diagnosed, what kind of cancer they had, what age that person was diagnosed with that cancer. If they've had breast cancer 3 times, I care when they were first diagnosed. I care when they've had their subsequent diagnoses, but I really care about that first one, right? Because then we can sort of guess at the others. And if there's any positive testing in the family, I love to have the results. If your mom had this gene, let's see what mom's gene was.
Yes. Yeah, there's a lot of genes that sound almost exactly alike. So it's not uncommon for somebody to come in and verbally report a BRCA2 genetic mutation, for example, but we just don't have the report to look at. And so lo and behold, we do multi-gene panel testing and we get a CHEK2 gene. And so there was just some confusion as far as what exactly is going on, because it all just sounds so similar.
Correct.
So family history of testing results are very important when you present to a genetic counselor.
That's right. It's hard sometimes to get a hold of those results, and they're not a deal breaker during an appointment. But if you have it, then it's easier for us to counsel you and say, oh, okay, so we know that you've got this CHEK2 in the family. Let's talk about specifically what CHEK2 is, since that's really the one we're digging for.
Right, and we would like to confirm that, right? Because let's just say it was a variant, or it was actually inconclusive results, and the family history, it's, for example, it's a strong family history of breast cancer, and the genetic testing is actually uninformative. We don't want to undertreat those at-risk family members by misleading and saying, oh, well, this family history is actually proven to be due to something that you didn't inherit, so you're not at any risk, when in fact it's actually never been proven as far as causation goes. So it also is important in the long-term management. We don't underlook things either.
So, and that's an interesting point, because genetic testing can be positive. most genetic testing is negative, but then there's also that fun gray area that we all love and we all get referrals for.
Yes.
Yeah.
Because the results are a little confusing when you look at them, right? It says like results inconclusive, results unknown, results uncertain. And then it's like, do I need testing again? Because many things are what we call a VUS, or a variant of uncertain significance. Christen, you want to explain a little what that means?
Yeah, a variant of uncertain significance means that we just don't have enough research, enough literature to understand if this change or in the gene, which is also known as a mutation, is a harmful mutation or a mutation that just makes that person and their DNA unique. And so when we see these VUSs, we as genetic specialists are able to look these up. The NIH has a lovely database where everyone all over the world contributes their data. And then we can tell, well, how do other labs classify this? Because one lab may classify it as a VUS, another may classify it as likely benign. There's other situations where I've had a VUS and another lab, says, hey, this is likely pathogenic. There are many, there's big differences in how we manage those people. And obviously we also look at, their family history to help us. If I have a patient who comes in with a VUS on, say, BRCA2, and their family history is suggestive of BRCA2, and I go to the NIH's database and I look at this and I look at all of the data that supports, a lab that says this is likely pathogenic, then I'm going to up, the treatment on that patient to manage them similar to someone who may have like a BRCA2 mutation until we know otherwise. So we would do increased breast screening, increased screening or prevention for their ovaries, these types of things.
Yeah, and it's also important to note with genetic testing, I think the biggest misconception I see when we sit down with patients is that we are going to test them to see if they have the genes. But these are actually genes we all have. We're built with them. The majority of these genes that we look at are ones responsible for protecting us against getting cancer. And so I always use that similar book analogy. It's like, imagine having a bookshelf full of books and each book on the shelf represents a gene. We're just going to go down your bookshelf and really read every book from cover to cover just to make sure that it's built in the way that you can read it. And so you could rewrite a book on the same subject 100 different times and read it either way. So we're always expecting those unique genetic differences, but it doesn't mean that it is harmful necessarily in any way.
Yeah, the other thing with this type of testing that's a common misconception is we're testing you for cancer.
Yes.
So when we get these results back, it's, we say, oh, you have a BRCA2 mutation, and it gives you a lifetime risk of cancer. It does not say you have breast cancer cells floating around in your body. It doesn't even mean you're gonna get breast cancer. It means that your lifetime risk is that 50-60%. But on the flip side of that, there's also this 40-50% risk you're never going to develop cancer, right? So I frequently am counseling people and they're saying, so you're going to tell me if I have cancer? No, I'm not going to tell you if you have cancer. I'm going to tell you what your risk is for cancer.
Yeah, I always tell patients, number one, this testing doesn't tell us if you have cancer. Number two, even if it's negative, it's not a guarantee that you won't go on to develop cancer because the majority of the time it's sporadic anyways. And number three, even if we find something, it's not a guarantee that you will.
Correct. Yeah, which is sort of a scary thing for people. I think that's one of the things when I go into appointments is that I always try to sit down and kind of explain myself first. Like, this is who I am and this is what I do. You're not at the cancer center because you have cancer. This is not going to tell us if you have cancer because it's a little bit scary. They're walking into a cancer center going, why did I get sent here? I had an abnormal mammogram 2 weeks ago, right? And now they're panicking a little, which is completely understandable that this isn't, genetics is still in its infancy. Right. I mean, in terms of this kind of testing, we all started testing years ago when we were testing for 2 genes. Right. And then the panel came out and the panels get updated regularly. And now we're testing for far more genes than we ever thought we would. And we get new data on them. How many times have we seen things downgraded from, well, it was associated with colon cancer. Now it's not. Right. So this is also the reason we keep checking in with patients is that, as these genes evolve and as the data behind them evolves, maybe we don't need to screen you for that type of cancer anymore. Maybe we should screen you for this other type of cancer. So that's a reason we keep checking in with people, because we keep checking the data.
Excellent point. And actually building on that, once people do test positive, we do establish them if they're interested in our high-risk hereditary carrier clinic. Essentially a fancy name for we will take care of you, we will manage you, we will, order all of your surveillance and screenings and help them along the way, because people are at different phases of their life. Some people haven't started their families yet. They may be very young. And so we help them, process, and we help them to decide when the timing is right for certain things, such as preventative surgeries and such.
Yeah, absolutely. That's a great point. Stay up to date with those cancer risks. NCCN guidelines update literally every 3 to 6 months. We are always going back to reprint off guidelines to make sure that we're up to date. And then when we see patients in clinic, as we go down the line, we pull out our guidelines, see what mutation they have, see what's changed since we saw them last, to make sure that we're always up to date with screening recommendations. Try to do a nice job at making sure that nothing falls between the cracks, because they do require a lot of intensive surveillance, but also that special attention to stay updated with those guidelines.
Absolutely.
So as we kind of wrap up, any other sort of topics we've left off, anything we want patients to know? This can get complex very quickly, but
there is a really nice support organization called FORCE, or Facing Our Risk of Cancer Empowered. And essentially they provide support groups. They have, I think, a Facebook page that's private. They have folks that will meet with them and talk them through and support them along the way if they have any questions. Sometimes they'll actually pair them with people who are in a similar age bracket with a similar genetic mutation, for instance. Not alone.
Yes, and not alone. And lastly, I'll just say is, even if you're still hesitant, I always tell my patients, consider genetic screening like any other screening that you might seek. If you're a woman and you're 40 and you get your screening mammogram, you're screening to be proactive, because we all may be at risk for breast cancer. Now we have the sophistication to screen your genes to see if you're at risk for other things that maybe you would never otherwise be screened for. So it is impactful as far as giving patients the opportunity to take some of that power back.
Yeah, 100%. The other thing that I would add, which I again talked about a little earlier, and I've gotten a few of these referrals lately, so it's like in the front of my mind, are these direct-to-consumer testings, right? Where people go, okay, so I've been genetic tested, and they do some forms of genetic testing. All the companies are slightly different, but also if you get referred to a genetic counselor, bringing those in so that maybe those can be looked through and kind of explained, because some of them are only testing you for certain types of genes, right? Like these BRCA ones are frequently the founder mutations, which are actually only found in the Ashkenazi Jewish population, which is a very small number of them. And so they're telling you you're BRCA 1 and 2 negative, but are you really? Were you even tested for the right set of BRCA genes, kind of thing? So I tell people, proceed with those with caution. And if you do come to your appointment, those are all kind of a handy thing to have with you. Right.
No, I totally agree. I always tell people to proceed with caution when it comes to direct-to-consumer testing. And the reason is that there's a lot of ambiguity there. Patients don't really realize that those genetic labs are not really reporting things that we can easily interpret. So they might find something that's somatic and just call it a positive change or a pathogenic mutation, when actually in reality it was a somatic change and they were not born with anything that puts them at higher risk. And it can be quite confusing for providers even, and for patients. And so we always like to essentially validate the testing and repeat testing with one of our CLIA approved labs.
Yeah, those like 32, 35 page packets of like, these are the results, and I'm always looking through them going, all right, I need a minute to go through these. But yeah, Kristen's absolutely right. Usually whatever's on there, we're validating with a different kind of lab and in a different testing, different setting. So, yeah. Okay. It was fun, girls.
Thanks.
So much fun.
So that's going to wrap it up for this episode of Cancer Close Up. For me, Christen and Amanda, everyone here at the WVU Cancer Institute, I'm Samantha. Have a good day.